Hello and welcome back to the Advancing Healthcare Innovation Show. I am your host, Michael Stamatinos. And if you're new to us, we are incredibly excited to have you here because we are bringing some exciting conversation with some amazing leaders that are painstakingly shaping and reshaping the future of healthcare. And we happen to be crazy passionate about a number of different things. We're passionate about innovation, adoption, access, and leadership. And if it's your first time tuning in, let me just sort of take a quick step back and tell you what we are doing here. So we're focused on bringing real stories of innovation and leadership to life, not just theory. We're also talking about folks that are really doing cutting edge work and giving them the opportunity to share their stories with our community and ultimately with the world. If you haven't had the opportunity to check out any of our historical interviews, wherever you are, however you're consuming this, whether listening to it or watching it, just make sure you hit the subscribe button now so that any of the new interviews come right to you. We have an action-packed year, incredible folks that are coming onto the show. It's really exciting and great stuff. And in our field, because it's consistently evolving, it's crucial to have leaders that can envision the future differently while also embracing innovation to address pressing challenges. And as you know, there is no shortage of pressing challenges, which means that there's an opportunity to lead through them and to innovate and to make things better. So our next guests, we are very lucky today. We have two guests coming on the show at the same time, are two individuals who aren't just analyzing trends, but actively reshaping the scaffolding of how care is delivered, measured, and valued. So first up is Dr. Andrew Hurwitz. I'd say he's a powerhouse at the intersection of data science, commercial strategy, and evidence-based advisory. So as the director of the healthcare and life sciences practice at Mathematica, Andrew leads with purpose, helping clients ranging from providers and payers, med device companies, and life science innovators really convert complex evidence into actionable impact. And he's part scientist, part strategist, part architect of what comes next. So whether it's building geospatial tools for claims data analysis or leading groundbreaking studies using smart sensor mouth guards in youth football, Andrew brings a rare mix of rigor and relevance. And joining him is Dr. Jeff Ballou, an economist by training and a reformer by passion. So Jeff's expertise in alternative payment models isn't just deep, it's foundational. He has advised some of the most consequential Medicare payment reforms of our time, helping rewire incentives to reward value over volume, from bundled payments to clinician-focused models. His work is really bridging policy theory and market practice, always with an eye on creating more equitable, sustainable, and high-performing systems. So together, we have an opportunity to bring two rare and potent combinations. So statistical precision, strategic clarity, and just a fierce dedication towards moving the system forward. So this is the conversation that's going to challenge assumptions, spark new questions, and give you a front row seat to the ideas that are shaping tomorrow's healthcare economy. So Andrew, Jeff, welcome to the show. It's great to see you guys.
Good to be
Good to
here.
be here, Michael. Thank you.
Uh, Mathematica has long stood as sort of the gold standard for evidence-based research and policy impact in healthcare. I think today we're really going to be doing something a little bit different. We're entering the private ACO market, with the same sort of intensity and precision and mission-driven rigor that you've brought to the public sector for decades. And I'm just really excited about that. Andrew, maybe we can start off with you. Just share just a super high level for someone who hasn't heard about Mathematica. Tell us a little bit about the firm, and then we can kind of dive in thereafter.
Michael, my pleasure. And so Mathematica is a mission-driven organization, and heard you use those words, more than once already, and that's absolutely core to the organization and every employee that works here. We're employee owned, which I think is also a defining characteristic of ours and one that distinguishes ours from others that work in the space. It really enables our employees as a collective to pursue those opportunities that we feel are in line with that mission. And that mission, as you mentioned, is to improve public well-being through the use of data and evidence. And the foray for us into the private sector started actually a number of years ago now. And as you noted, I have the distinct pleasure of leading it. We have a dedicated team across business development, strategy and operations, and project delivery that lead it. And then we have tremendous support from colleagues like Jeff, who are with us today, and others that have delivered Mathematica's core services to our core clients for a number of years, and now are helping to support our business diversification efforts. And for us, fundamentally, being employee owned, being mission driven, it's all about where are opportunities to expand that mission and expand that impact for the client. Because if we're not doing that, then we're not living to the ethos of why we're all here as employees and stewards of Mathematica. And so that was our focus in thinking about where to move next. And in particular, as Jeff can probably illustrate us for a bit more in some of his opening remarks, Mathematica is one of the premier trusted advisors at CMS. And we've done lots and lots of work across the Medicaid and Medicare program, lots of different types of work, from technical assistance projects to research projects to digital solutions projects. And me and my team, in collaboration with Jeff and others, really have the distinct pleasure of figuring out all that IP that exists around understanding data elements, understanding policy and program, deep methodological understanding in econometrics and statistics and data science. How do we package that all up, whether they be more pure professional services offerings, more digital offerings, and offer those services to private sector clients? And one of the areas that we've decided to focus on are accountable care organizations. And I think that focus makes sense for a couple different reasons. One, as you all know, and I'm sure many of your listeners will know, there's the mandate that I believe by 2030, all physicians continuing to accept Medicare fee-for-service will have to be part of an ACO, right? And there are a difficult set of choices that need to be made wherever you are as a physician group along that journey. Or you just sort of starting to figure out, noting that Medicare fee-for-service will be part of your practice in the years to come, and so you recognize you need to be part of an ACO. Well, we can help you. Or are you a more sophisticated ACO that maybe has really well-developed analytics that you feel help you understand your risk and understand your quality and measure your return? Well, we can probably maybe help tweak the edges in some of that, right? And then everything in between. So that's really grounding sort of our focus and diving a little bit into why start with ACOs and what is a vast kind of private sector market. So
That's right. And Jeff, maybe kick it over to you. Maybe what's something that doesn't show up in your professional bio, but really has everything to do with how you lead today?
Oh, I guess I would say that I've always been curious about what the answer is. Even I've always liked solving problems, and I'm a little bit reluctant to even be too confident of my own beliefs. That can get me into trouble at times. But I just am fascinated with this notion of when you have a really hard problem, and healthcare in the United States is nothing if not really hard. Where are we falling down? At a high level, we know where we're falling down, but what are the solutions that continue to elude us? Where are we missing? And so I've been attracted to Mathematica and the work we do here because the through line for everything that Andrew was talking about in all of our past and now our future, helping organizations and providers in the private sector, is this notion that we're all about developing extraordinarily strong, rigorous evidence. And it's almost an irony, and this very well fits my personality, of the way we work here. We're generally quite passionate about wanting to solve some of these problems. And yet, for many of the roles we play in the work that we do, we have to be utterly dispassionate. We have to go where the evidence leads us. And sometimes that means we have to confront that a cherished belief might not be quite what we thought it was. So there's a part of me that's very much aligned with the work that we're trying to do here.
That's great. And I'll just sort of kick off a little bit deeper. So I mean, Jeff, you've had a front row seat at CMMI, and what's something that most health systems or even payers misunderstand about the intention behind recent ACO related reforms?
Um, I won't claim, obviously, to speak for everyone, but I think often there's a misunderstanding, and the misunderstanding can exist on both sides, providers and payers. But I think oftentimes providers misunderstand just how deeply payers care about getting a well-functioning system. Oftentimes you see new rules, you might see mandates that providers don't like. And we can understand why they don't like them. They're constraining. They threaten revenue streams. But having worked now for years with providers, but also the payers, it's remarkable to me how committed folks are on both sides, really, to making the system work. And I think one of the roles that we have at Mathematica, as we work with both payers and providers, is trying to help bring those two perspectives together. So, for example, you see in the ACO world right now, where and I imagine many of your listeners are familiar with this notion of the accountable care organization. It's basically a group of providers who agree to take responsibility for patients that are assigned to them for all of their care, for the quality of all of their care, and for the cost of all of their care. And that includes the care that are provided by others. So if I'm an ACO, for example, that's primary care oriented, and my patients go to the hospital and then they go to post-acute care, I'm on the hook for all of that care, the quality
That's
and
right.
the cost. And one of the things that we're seeing with ACOs right now is there's a program that's the largest ACO program in the country called the Medicare Shared Savings Program. They will continually be trying to tweak their rules to strike a balance between attracting participation, because they believe strongly that this is the way to provide care and save money for the US taxpayer, while also being able to achieve those savings. There's a balance to be struck there. And one of the things that they're doing right now is they're introducing something called a prospective trend, the accountable care prospective trend. And without getting too much into the details, unless it makes sense to do so, it's essentially meant to give ACOs a bit of a heads up in terms of what their targets are going to be at the end of the year. The ACOs are asked to save money. What's that amount going to be? And again, it's a little bit wonky detail, but ACOs typically don't know that amount at the beginning of the year. So you're almost aiming for a set of goalposts. You don't know where they're going to land. And this prospective trend is meant to bring some clarity to that. And it turns out that this prospective trend is very difficult to set. And so one of the things that we're seeing right now is, if you get the trend wrong, providers are going to be unhappy. And trends are very difficult to predict. There was something of a miss this year with CMS. And right now we're sort of, as a policy community, wrestling with this question of, okay, what should we do about it? But I think lost in a lot of this is the intention of trying to make things better for not only patients, but also providers when you're rolling out these very complex problems and programs.
Yeah, I mean, you mentioned this around, if you don't know the target that you're trying to hit, then you're going to hit it every time because you're surely going to miss. That's
Exactly. Or you'll
that's
miss it
very
every
interesting.
time.
You'll
Yes.
miss it every single time. Andrew, there's been this, I'll just say there's been a perceived lag often from between federal innovation and commercial adoption. I guess what's your sense? Are commercial players proactively positioning for the next wave of policy, or are most still reacting?
It's a good question, Michael. Really good question. I mean, I think, what's that tug of war kind of who innovates
Yeah.
first, right? And who kind of guides that direction. I think, and Jeff, please jump in too, but I think that the general sense that I've concluded is that most are optimistic, but sort of wait and see, right? How will sort of new administration priorities influence some of the decisions we have to make? How much will kind of legacy programs remain, if you would, and if you will, and how much can we benefit from knowledge that groups like Mathematica have, and but all I think are future leaning, right, and are aware that they need to stay on top of however the policy landscape evolves, because it certainly will affect them, right? So I think there's cautious caution about how the landscape will shift, but a recognition that they just sort of can't wait and see then how that shift affects them. They need to be having conversation. They need to be having dialogue and preparing
Yeah.
for that inevitable shift.
And this can be a real challenge, right? Because a lot of these problems that these providers are trying to solve are not short-term problems. So they're thinking about making longer lasting
Yeah.
investments, realizing that the policy environment can change. If you're a nephrology practice with, you've got chronic kidney disease patients, that's not a short-term relationship. It's not a short-term commitment. So I think one of the
Right.
challenges that providers face is this question of what's coming next. I can't get too far over my skis because the world can and will change. But at the same
Right.
time, I do need to make some decisions about the future now.
Mm. You mentioned around Andrew, you mentioned around analytics, and you and the team have built analytics tools to translate this raw data into high impact operational insights. When you look at the current state of data in ACOs, what excites you? What frustrates you? Thoughts?
It's a good question, and Jeff may be able to offer deeper insights from what he sees too. But I think I think maybe initial reactions are honestly maybe surprise on some level as to the date. The data's there. They know how to access
Yeah.
it, right? They know how to even potentially get it over to us, right? Right. But it's probably a little bit more disparate, separated. Definitely requires a little bit more effort around massaging and kind of weaving together than maybe ideal per se, but that's why we're here. It's not just about kind of working with the clean data set and creating the model. It's about how do I build that clean data set, right? How do I build that? We talk a lot about as we're going through our PhD program, and then we're off on our research projects. What's the research grade ready data, right? It actually takes a lot of effort to get to a
That's right.
research grade ready data set, right? And it requires intimate knowledge about how to stitch together those data elements to make it meaningful. And we have the capacity and the team to do that. So I think that is another value differentiator for us, that we can come in and help stitch together these different data sources, how you govern that data, etc., to eventually develop that analytic file that's going to be useful.
You said something in a previous conversation that sort of stuck with me, and it was really around, you know, shaping the right question. Because,
True.
like you said, can you maybe riff on that a little bit? And Jeff, feel free to add in on that as well.
It's a good part. I mean, I think it's a true I think it's a true kind of inherent picture to when you work with Mathematica, that sometimes we even internally I think underappreciate the value of what we can offer, right? You spend how you think about the question and how you think about the goals and the objectives that you want to achieve really does influence your success. And that may feel like stating the obvious, right? But I think that deliberate and careful reflection about what those goals are, and in particular, how then the data assets that you have access to and what that kind of data pipeline looks like to get you to where you want to go are in particular very important in considering those goals and objectives. And so one of the things that we will often suggest to our customers is a short-term discovery engagement. These are relatively quick turnaround, kind of low dollar value engagements where what we seek to do at the conclusion of them is put them on a pathway to an actionable project, right? And that's a project, that's a pathway that we hope they will then want to contract with us and move forward with us, but they're able to take that. That's a living document that they can take and go elsewhere with, right? If we're not a good fit. But there's that inherent value in using the Mathematica mind to help discover how you frame and shape that question with the assets you have available and the assets that we may need to bring forward.
Just to double down on a couple of Andrew's points, the knowing what questions you're trying to answer is so important. If you don't start there when using analytics or trying to bend analytics to help your organization, I like to liken that to building a bridge halfway across the river. So every now and then, especially if you're an organization that's not new to healthcare or healthcare delivery, but maybe a little bit newer to making the shift to proactive, data-driven, population health level decision making. There can be the sense that you keep hearing this message. It's all about the data. You need the information, and so you think to yourself, okay, I need to go do analytics. I need to go get analytics. So I get this great solution, but if I'm not thinking about why I really need that for my particular circumstance, because every organization is different. Okay, it's a little bit like building the bridge halfway across the river, and if you don't do anything more, you're just driving off into the water. You want to build the bridge all the way across the river, which means that you're connecting up all these data capabilities that you're investing in and these solutions you're investing in to, for example, your workflows. So it's not like you have all of this information sitting there and you've got, even great partners, maybe like Mathematica, helping you with that, but then your nurses never get that information. Or they do get it, but it's the wrong information on the wrong day. Or it just hasn't been worked into, again, their training and workflows. How am I going to use this information? So it's really important, if you know where you're beginning, you can then tailor your analytic solution to give you a shot at success. And again, one example is that, some ACOs that we're talking to, it's rehospitalization or hospitalization for folks who are really sick. They have multiple chronic conditions. And that's the issue where they are particularly focused right now. Other groups we're talking to, it's post-discharge communications from an acute care stay. Okay. And so there are different problems that you're trying to solve. At some level, there's probably some commonality. We know there's some commonality, but at a different level, your level of readiness, the problems you're trying to solve, it's so important to understand that before you go after an analytic solution. You're much more likely to be successful if you do.
You said something that triggered a thought in my mind, just really around how do you think about there's sort of like this tension between sort of statistical purity and real world decision making. And, when is good enough? They're just having known many operators and leaders, when is good enough truly good enough?
And is this a question about, how precise do my estimates need to be before I can trust them and run with them? Is
That's
it a
right.
question?
Yeah.
Yeah, I think one of the things that people who are not physicians, people who are economists like me, continually need to be reminded of is the human element can never go away here. So when you ask your question, Michael, what I'm envisioning is I'm envisioning a piece of paper with lots of dots on it. And that's sort of an analogy to a population health management perspective. I'm looking at all the dots at once, but you can't forget that some of those dots are actually individual people, right? And so even if you're making decisions based on this piece of paper that has a bunch of dots on it, at some point you need to zoom in. And it's possible once you zoom in that you learn that those clues you were taking from your population health level data were accurate and could be trusted. And in other cases, they can't be. So you can envision, for example, you're using that piece of paper with all of the dots on it to prioritize. I'm not just going to be reactive as a medical group and just, whoever makes the appointment first, that's how it goes. I'm actually going to be looking at who's at greatest risk for hospitalization, for exacerbations. I'm going to try to identify those people, and I might have a slightly different approach to treating them. Whereas those folks who are actually looking quite healthy, there's not a lot wrong with them. But for whatever reasons, perhaps they're using the emergency department a little bit more than we would have expected. We'll have a different approach for them. But ultimately, you're talking to each of these people, and you might figure out that you're wrong. And so I think it's ultimately that human element. There still has to be the human contact, and that's what helps you. The data can guide you, but it's a little bit like, using GPS in the early days, and all of a sudden you're on a logging road in the middle of Oregon that ends in the middle of nowhere. And that's because you trusted the data blindly. And we would, as much as we believe in data, we would never advocate for that. There's always got to be recognition. You've got a real person on the other side. You need to address that.
Andrew, comments around that, or?
Well said. I love the GPS Oregon example. Couldn't have thought of a better one myself.
Yeah, Andrew, this one's sort of for you. When you see sort of ACOs that are trying to mimic government models, is there a sort of a biggest mistake that you typically see them make, and what are some things that they can kind of avoid from a pitfall standpoint?
I think it's primarily those groups that newly have endorsed the model and maybe don't quite understand it, right, as well as they should. And I think that's, in many ways no fault of their own, right? These are complex programs that are difficult to often understand the downstream effects on how it may affect operations. But that's probably where we see the most, and where there's opportunity. And important to know too that doesn't have to just be about predictive modeling, and actually isn't, right? That can be more about technical assistance and advising around deepening the understanding around how the program works and how it will impact the ACO.
Very interesting. I mean, if you had to pick one element to sort of anchor a successful ACO, maybe it's technology, people, culture, or payment model, which of these would you prioritize first, and why?
It's a great question.
Andrew.
I mean, I sort of live by I sort of live by an ethos of people, not projects, right? One of the folks at Mathematica are just so great. It's like, we obviously have our mission, but I would work on almost anything with these folks, right? So I would always say the technology and the operational processes are good tools to help the people work better, but always prioritize your people first.
Yeah, I couldn't agree with that more. That's I heard a well-known, nationally known value-based care leader and physician down in South Carolina. He was asked about the key to success at a conference a couple of years back, and he started his response. He said, "You really need a madman." And someone in the back of the room piped up and said, "Could it be a woman?" So he said, "You need a madman or a mad woman." But then he continued, and he basically said, you need someone who is more than a champion. You need someone, especially in the shift to value-based care, who is just so committed that they are going to run through walls, they'll run over people, they will do whatever is needed to make sure this survives. And so many of us have had experiences with the healthcare system. Unfortunately, many of them have not been great experiences. But I think many of us have had experiences with, and maybe it's not a healthcare provider, maybe it's a teacher, but it's some person in a serving profession who is just meant to be there and is continually going above and beyond. And you think about the physician who, after a long day of seeing patients, and maybe they get their kids to bed and they do their documentation, which is a whole other podcast. And then after that, they, at 9 p.m, they're calling up a patient because they can't seem to get the insulin stable. And they spend half an hour of that patient just talking them through, okay, we're going to try something different now. I think we've all known people like that. I think a lot of us have encountered folks like that in the medical profession. That long predates value-based care, but just to reinforce what Andrew is saying, that is so critical. I'm an economist. I love incentives. I love models. I love numbers. You can nail all of that. And without the buy-in and without the really committed leadership that we're going to make this happen, none of the rest of it's going to work.
Mm. Andrew, I'm going to kick something over to you, and I'm going to come back to Jeff because, again, you guys are saying some pure gold here. But Andrew, you've built a career on connecting research to impact. What keeps you grounded? And is there maybe a story or even a moment that re-centers you when the work gets abstract?
I think it's the impact on the people, and it's the opportunity to fulfill the mission of improving public well-being. And whenever I think about, the real breadth that I've been able to do so far in my career in terms of, spanning across projects and different impact, back to when, you cited, Michael, the work with the football team and getting to think about, hey, implementing, robotic tackling dummies, what's that going to do to reduce head impacts in youth sports, right? And in particular, in this case, youth football, and being up there working in the communities, seeing the kids, seeing the translation of that to injury, things like that. That was vastly fulfilling. And now, getting to partner with Jeff and seeing some of the impact that we have the potential to have with the ACOs in terms of, identifying patients that may be at high risk for, emergency room visits or hospitalization, and keeping, allowing the ACO to keep better track of them, where previously they wouldn't have known that those patients were the ones to look out for. That's powerful stuff. I mean, it doesn't get more meaningful than that at the end of the day, I think.
For sure. And Jeff, look, policy is personal, and you've done work, at the systems level. However, I'm curious, what was the moment or even the memory that made all of this feel urgent for you? Like, when did it shift from work to mission? You've said mission a number of times, but
Yeah.
was there something that happened? I'm
Yeah.
curious.
Yeah, there's always been, again, that more impersonal drive, just wanting to know the answer. That's been there from the beginning. But then more recently, I guess I've got two answers, one more flippant, one less so. I'm not getting any younger, Michael. I'm still a few years away from Medicare, but eventually I'm going to be there. And I want that to be a strong program for very selfish reasons, but I also want it to be a strong program, obviously, for family and loved ones. The more serious answer is, I think about the example of my mother, who passed away a couple of years ago. And she was an interesting case. Her endocrinologist always referred to her as she was a frail diabetic. She experienced the onset of type 1 diabetes, I would say, in her early 70s.
Mhm.
So maybe half a dozen, slightly more years ago. And at the time, she was also receiving immunotherapy treatments for stage 2 non-Hodgkin's lymphoma. And she had a couple of other things going on as well. And then in June of 2023, really the tail end of pandemic, she and my father got COVID for the first time. And my father recovered from it, and my mother, it went to long COVID, and then it was in the hospital. They were working on her insulin, they're working on her sodium, and by November she had passed away. So it was an unfortunate situation. She is a good example of, I think, both the promise and challenges of value-based care. And that's what I mean by
Right.
unfortunate. Obviously, for me personally, it was much more than that.
Mhm.
It was devastating. But when I think about it from a policy perspective, I think about, all the care that she had from her specialists, and yet the sort of thing that value-based care really aims for, this notion of we're prioritizing, we're risk stratifying our patients, and then we're treating them accordingly. We're providing chronic care, chronic condition management, care coordination for complex patients like my mom. I couldn't help thinking in the months after her passing that, gee, I really wish more of that had been available for her. Now, here's the kicker. Her PCP and her PCP's office is a longtime participant in multiple value-based care models. Okay.
Mm,
So one of the things that was really striking for me and something that's motivating me right now is that I think a lot of organizations, very well-intentioned organizations, have bought into the promise of value-based care. And they know at a conceptual level what they need to do. They need to do the risk stratification. They need to do the care coordination. They need to structure their teams. So it really is a team. You got physicians practicing at the top of their license. But then you need to figure out the tactics. What's the execution of all of this? Just like with the data and analytics. Okay, I know I need data. What do I do next? I know I need to coordinate care. Okay, what do I do next? How do I figure out these next very concrete steps? And as one person said in over the past year, reference to Medicare Advantage, but applies more generally, a lot of the low-hanging fruit is now gone. There was a time, especially in Medicare
right.
Advantage, where it was you could get that revenue without doing a lot of hard transformation. But this person went on to say that at the end of the day, ultimately in Medicare, you're going to run into older, sicker people. And it's an obvious thing to say, but it's almost as if
Right.
now you have to live that and you have to transform care and you have to get real about the execution. It's not enough to buy into the concepts. And so we're sort of at a crossroads. We're sort of at a plateauing with value-based care right now. And I think we're at that plateauing because this really hard work of care delivery redesign is still ahead of us. And that for me is a huge motivator.
Mm. And just to sort of wrap up, just to kind of get your thoughts here, I mean, let's just fast forward a few years from now. And what's the story that you want the market to tell about Mathematica's role in reshaping the ACO space? Andrew, I'll kick it over to you first.
It's a great question, Michael. I think it's that we are thought of as leaders in this space that are making real impact wherever you are on the ACO journey and whatever it is that you need, whether that's just having a better understanding about how a new program that you're entering may affect different operational aspects of your ACO, or whether it's we're really helping fine tune your quality delivery and your revenue reimbursement and helping provide more precision around understanding what that could look like. That's what it is, I think, for me. Just that
Mm,
that name when we talk with folks, I guess it would be, hey, that's Mathematica, they work for CMS. No, that's Mathematica, they work for the ACOs and CMS.
mm.
That would be it.
Jeff.
And I would hope people would say about us that Mathematica was never complacent and they never gave up. Again, the message I just ended on with the story of my mom is how hard value-based care is. And what that means is you can't keep trying the same things that didn't work before. And so whether we're working for payers, whether we're working with providers, we're not going to be complacent and suggest the same solution over and over again if that's not working. We're going to want to understand what is the problem, right? What is the problem you're trying to solve? It is so foundational. And then get in there and say, okay, well, let's try this. Let's try that. Just like my mom's endocrinologist did with her insulin. Okay, this isn't working. We're going to try something else. Mathematica was never complacent, never gave up, always kept striving with our partners to find a solution.
Tremendous. So Andrew, Jeff, actually maybe Andrew, you can kind of take this. What's the best way for folks to follow you, Mathematica, the team's work? Maybe just sort of give us a parting commercial and ways that folks can engage with you if they so desire.
Certainly, thanks, Michael. Well, you can always reach out to Jeff or I direct, right? Email, phone number is available on our website. Visit the website, visit us on all the socials. Mathematica has a social presence,
Yes,
and
yes.
and you can find us on LinkedIn, etc. And we're always happy to chat. We love to hear from folks and want to figure out ways to partner and engage.
Great. So for those of you, if you tuned in today and you found this conversation particularly enlightening and helpful, would you mind sharing it on social, letting us know what stood out to you? there were a lot of key, I'd say, golden nuggets in this conversation. Jeff, you, Andrew, you guys were very, very generous in giving us a lot to chew on, to think about. And um, the only thing that we can do as a community is to continue to work together. And as Jeff mentioned, it's never give up. If you want to make things better, it starts by understanding and knowing data and knowing how to shape questions. And, we've had two of the most trusted authorities in the industry, in my opinion, come on and share with us today. So Jeff, Andrew, it's been a pleasure. Obviously, you're open door for you guys to come back onto the show and share additional thoughts. So it's been a pleasure speaking with you today.
Thank you, Michael. Thanks for having us.
Thank you.